Thank you very much. So you are all against me, okay? It's a bad news to start with, but I... Sorry? Yeah. Okay. I will be clever. I won't give a contra. I will just qualify the contra or discuss a little bit more what Wolfram said about heart failure. So... So heart failure is a heterogeneous clinical syndrome, and many diseases end in heart failure. So that's the one thing. The other thing is it changes the prevalence with age. The other thing is it is always concerning patients with comorbidities. And these patients have number of additional risk factors. And also the degree of heart failure is important risk factor for stroke. And obviously the heart failure is typically combined with atrial fibrillation. So we had number of reasons. Well, we cannot just say heart failure is a risk factor, but we need to look at the individual problems of the patient with heart failure. And for cardiologists it might be boring, but for neurologists or colleagues from other disciplines it may be a little bit...
they can't hear about...
maybe a little bit more educational, I'm sorry about it. So we're talking about systolic heart failure, and systolic heart failure is associated with impaired ventricular contractility. It can be left-sided or it can be right-sided. There are a number of diseases involved. We have systolic heart failure due to increased afterload, and number of diseases on the left side are involved, and also on the right side of the heart. We have also diastolic dysfunction with number of special diseases, impaired ventricular relaxation, impaired ventricular filling, with number of diseases involving both sides of the heart. So we have very complex number of diseases which are called heart failure. The other thing is prevalence with age. Wolfram showed it already that it is increasing significantly with age, and we have in the geriatric population nearly every 8th or 7th patient have heart failure, but we have much less strokes. So the stroke incidence of younger patient, male patient, is much less compared to the incidence of heart failure in men and female. And this is the similar data showing for the female patients. So there is a large discrepancy between incidence or prevalence of heart failure and prevalence of stroke. There is also the other problem. This is the HFREF, patients with reduced systolic function. This is the comorbidities which are very frequent, and some of them obviously are independent risk factors for stroke as well. So it's not the patient with the HFREF, it's a patient with other stroke-prone diseases as well. This is just another example of patients with HFPEF with preserved left ventricular function. Also similar picture, a lot of diseases, lot of problems which can represent stroke risk in these patients. And also important factor in patients with HFrEF is the degree of heart failure, and you see the rate of stroke. In these patients, the patients who have relatively better preserved left ventricular function have much lower incidence of stroke than those with poor left ventricular systolic function. And also the disease is very closely pathophysiologically related to atrial fibrillation. So many factors participating in development of left ventricular dysfunction are secondarily or primarily related to factors which cause left atrial dysfunction or left atrial sponsored atrial fibrillation. And we know that, for example, the biological studies of patients with heart failure showing the endothelial dysfunction in the left atrial appendage, for example. So these patients are not prone only to atrial fibrillation, but also to development of thrombine in the left atrium, particularly left atrial appendage as well. And also there is a lot of interdependence. If you treat these patients, you treat both factors, you treat both heart failure and you treat also the atrial fibrillation. Just to close, yes, the risk of stroke is increased, but the number of other factors, individual factors, must be considered. So I wasn't saying it's not the case. Stroke is most likely associated with higher risk, or heart failure is most likely associated with increased risk of stroke, but we have to look at the patient and see what kind of heart failure he or she is, and what you have to do about it. And importantly, there is no recommendation, for example, and it has been long-term discussion in cardiology, should you treat patients, for example, with left ventricular dysfunction and left ventricular thrombus, which is organized and chronically present, should you treat these patients with anticoagulants, anticoagulate agents or not? And this is open discussion still.
Didn't answer the question.
So thank you very much.
No treatment.
Okay. Thank you very much. I think that we've heard both sides of the, but not necessarily someone totally against each other, but from different point of view.
Peter wants to say something.
Yes, Peter.
This was a difficult topic because there are really few data. So I just want to comment on what Wolfram showed, that the risk of stroke in those published studies was greatest in the first 30 days or less than 30 days. I wonder if this can be related to in-hospital strokes, and if so, if it can be related to some periprocedural strokes. Because if this is the case, then some ways of treatment of heart failure, I mean invasive treatment and different assist devices and so on, they can actually increase the risk of stroke in heart failure patients by treating them. So can you comment on this?
Yeah, studies did not differentiate the reason for that stroke. I mean, certainly it is a higher prevalence of in-hospital events. It is a high prevalence of in-hospital events during this first 30 days, because those people obviously have been diagnosed most likely for an acute cardiac decompensation. It's not necessarily the case that they had an invasive therapy at that moment. Some of them might have had, but some of them as well might not have had an invasive diagnostic or treatment, but only a cardiac decompensation with edema and need of IV treatment. So I can think of a number of reasons why it is in this early time so high, but this has not been specifically addressed in the publications.